2, 1.
Very good evening to all my dear MOS members. Once again, we are back with the e-Journal Club. This is the third meeting that we are having in the month of January. So wish you a very, very happy new year. It's almost a month down the line, but the first of the e-Journal meet in this year. And we have the experts with us, the panelists, Dr. Himanshu Matalia, and our own boss, that is Dr. Chandrasekhar Vavikar sir, and Dr. Vaishal Kenia and his team, Parul Deshpande and Dr. Naina Poddar. They are doing great work to see that every month to month we are coming with very interesting articles, and this time we have got IOL power calculations in cases of keratoconus. It's a review article, and I wish all the best to the Journal Club committee. Over to you, Vaishal.
Thank you, sir. And with so much enthusiasm and energy, it pumps up all together to do much better every month, and we try to emulate and do much better. So today's article is a very interesting article on intraocular calculation keratoconus. So we are trying to find more and more fortes we want to manage, like post-refractive surgery cases. Now keratoconus, we want a better formula to give us a better outcome. So today we have brilliant panelists which have a lot of experience on keratoconus, and it would be great to share. So I hand over the meeting to Dr. Parul Deshpande to conduct it further.
Thank you, Vaishal. So at the outset, I would like to thank MOS, and I would like to welcome Dr. Chandrasekhar Vavikar. I think he does not need any introduction. He's the head of the Vavikar Eye Institute and a very esteemed member of MOS. And we have Dr. Himanshu Matalia, who is a cornea consultant from Narayan Netralaya, Bangalore. We have our presenter, Dr. Mamta Tanna, who is from Vavikar Eye Institute, and she would be presenting on intraocular lens calculation in eyes with keratoconus. I have my co-moderator, Dr. Naina Poddar, who is head of the unit and professor at Lokmanya Tilak Medical College, Sion Hospital. So with this, I think I would request Dr. Mamta to share her presentation. Mamta, you can start sharing, yeah.
Sure, ma'am. Good evening, everybody. Myself, Dr. Mamta Tanna from Vavikar Institute, and my moderators are Dr. C.M. Vavikar from Vavikar Institute and Dr. Himanshu Matalia from Bangalore. Today's topic is intraocular lens power calculation in eyes with keratoconus, which was published in JCRS in 2020. The impact factor of this article is 3.351. Purpose, as we all do cataract surgeries in keratoconus eyes, here is to review and document the method used to calculate the power of intraocular lens which we implant in these surgeries. This review includes all the scientific articles published that focused on parameters and formulas used to calculate this IOL power. As we all know, keratoconus is a non-inflammatory disorder characterized by increasingly steeper cornea of central and paracentral region, leading to refractive errors. Management may vary. In mild cases, we may give spectacles or contact lenses, and in advanced cases, we may need surgeries like C3R, ICRS, or keratoplasty. The problems in keratometry measurements in keratoconus are the decentered cone may impact the precision of keratometry readings. Usually, standard refractive index is used to calculate the keratometry values, but it may not hold true in keratoconus eyes as there is alteration in anterior and posterior corneal surface ratio. Visual axis may not go through the cornea's steepest location, which may hamper the K values, which will be less precise. Also, the irregularity of tear film reflexes makes it difficult to identify reliable and repeatable K values. Methods. Bibliographic search was conducted for scientific articles written and published before 15th of March 2019, which yielded 851 articles. Boolean operators and truncated terms were used to perform the search. Selected articles which had not been included from the above search were also screened. As a result, 19 articles were finally analyzed and reviewed. Inclusion criteria is patient with keratoconus who had cataract surgery, patient with keratoconus undergoing cataract surgery with no prior history of ocular surgery for keratoconus, explicit mention of how eye power calculation was done. Results: Kami et al. Performed multicentral study, which was the largest, including 102 eyes. Keratometry measurement method used was total corneal refractive power measured by pentacam on central 3 mm ring and IL master for IL power calculations. These were the formulas used for this study. Conclusion: accuracy was good in mild keratoconus cases, but not in moderate and severe keratoconus. There was large amount of hyperopic or myopic shift occurred in advanced cases. Hence, it concluded that standard keratometric index is not always, it gives overestimation of corneal power. Watson et al. It is a retrospective study. It is a very interesting study, which included 92 eyes. And the method used was IL master 500 or keratometer for mild to moderate cases and severe cases also. In addition to this, in advanced keratoconus cases, he divided standard K values were used in 50% of cases, and actual K values measured from the above methods was used in other 50% of cases. Conclusion: K values as actual K values are suitable for mild to moderate cases, but in severe cases, standard K value was better, as depicted is in this table. This is the preoperative data of all the 92 patients which were studied in this study, which shows that out of 92, 27 patients were using glasses, 57 were using RGP corneal contact lenses, and 8 were using scleral contact lenses. And postoperatively, when the spherical IL implantation was done, after that, it shows that there was a very good improvement. In mild cases, patients were glass-free in 8 cases, while there was improvement in the refractive error, as the number of scleral contact lenses and corneal contact lenses number was decreased and glass number was increased. Even the biometry prediction error was very less, in almost 0 in mild keratoconus cases, which was moderate, in even less in moderate keratoconus cases. But as you see, it was very big when the actual K was used in severe keratoconus cases, though it was less when the standard K value was used. Hence, and even the range you see is very big and when the actual K was used in severe cases. So this shows that standard K value is better in severe keratoconus cases. Next study is Savini et al. It included 41 eyes. Keratometry measurement method used was corneal curvature data converted to corneal power by standard keratometry index, which was measured using biometer or topographer. These were the formulas used in the study. And the conclusion was SRKT was the most accurate formula in mild to moderate cases. In severe cases, the residual error was almost always higher than 2.5, as depicted in this table. Here you can see the SRKT formula is almost giving 100% result in all the stages, and the error is always less than plus or minus 1 diopter. More or less similar results were in moderate cases, but in stage 3, that is severe, it was less than 15%. So in severe cases, the error was always high, using in even the SRKT formula is used. Next is Lesisotti prospect. It is the only prospective study which included 34 eyes. K values obtained by axial topographic maps were used. Holiday formula was used, and refractive, it concluded that refractive lens exchange in keratoconus eyes predictably corrected myopia. IOL exchange occurred in almost 50% of cases, that is around 11 eyes. So it recommended intraoperative autorefractometry is better. Hashimi et al. Is a retrospective study including 23 eyes. Manual K and K derived from pentacam is used. According to the axial length, different formulas were used for different axial eyes of different axial lengths. And error obtained with this manual K and with this study was very less for mild and moderate cases, but in severe cases, even in severe cases, hence recommended that K should be measured in the central cornea, which correspond closely to the visual axis. So in all the cases, the mean absolute error was very less. So it recommended K value should be measured in central cornea, which correspond closely to the visual axis using manual K and K derived from pentacam. James et al. Included 19 eyes. It also considered keratoconus frustae and pellucid marginal degeneration cases. Pentacam or Opscan 2 was used for measurement. It concluded that 98.16% correlation between the attempted versus achieved refraction obtained. Alio et al. In this, he implanted toric oil in all the cases. Corneal topography was the method of choice for measurement. It also considered visual acuity and refraction. And formulas used were Hoffer-Q and SRKT. Conclusion is microincision surgeries using corneal topography for the calculation of IOL power is safe and effective regarding visual and refractive results. Weiser et al. Also in this study also, toric oil was implanted in both the eyes. K was measured using pentacam and axial length. For axial length measurement, manual keratometry was used. Conclusion, patient showed marked improvement in uncorrected distance visual acuity, and there is a significant reduction in refractive astigmatism with this toric oils. These two studies were done for posterior keratoconus cases. First is Tamauke et al. It studied 4 eyes. IOL master and autokeratometer was used for measurement. It estimated entire corneal refractive power only from the anterior corneal radius using modified refractive index by empirical estimation of the corneal thickness and posterior surface curvature. Anterior segment OCT was also used. Formula of choice was SRKT. Conclusion, total corneal power was lower than the values determined by the IOL master and autorefractometer. Hence, concluded total corneal power values that take both anterior and posterior corneal curvatures into consideration should be applied for IOL power calculation in cases with posterior keratoconus. Park et al. Studied 1 eye of posterior keratoconus where the axial length was less. Conventional keratometer, pentacam and Opscan was used. These were the formulas used in it. IOL power calculation from the conventional K may be inaccurate, may cause hyperopia. Best outcome obtained when exact central value in true net power map and equivalent K derived from pentacam was used. Selikol et al. Is a case report of 2 eyes of same patient in which right eye had central keratoconus and left eye had oval inferotemporal keratoconus. Standard keratometry was used for right eye, and for left eye video keratography was used. And these were the formulas used for respective eyes. In conclusion, determining the IOL power with video keratography derived values in different rings may be more accurate than the standard keratometry values. Next study is Steph et al. Studied 12 eyes. Standard keratometer and corneal topography is the method of choice for measurement. An average of all the IOL powers were taken into consideration. And conclusion was SRK2 was most accurate in patients in mild cases. And there was no difference between standard or corneal topography derived keratometry. Last in Camps et al. Showed that variable refractive index over the standard refractive index could minimize refractive surprises after cataract surgery. Discussion: refractive index of 1.3375 overestimates the corneal power, leading to hyperopic shift. Total corneal power leads to better outcomes, though corneal location for measuring the same is not specified. SRKT formula yielded the best outcomes. Higher the keratoconus, less predictable the post-operative outcomes. The incision position should be planned according to the peripheral corneal thickness rather than the astigmatism axis. Clear corneal incisions to be sutured to ensure wound apposition and to regularize the astigmatism. More studies with larger study population are needed to calculate corneal power based on not only keratoconus severity score, but also on position of the apex related to the center of the cornea. Key points: IOL calculation in patients with keratoconus remain a challenge for today's cataract surgeon. Patient counseling regarding difficulty of measurements and possibility of refractive surprise remains paramount to success. Toric IOLs may be considered in patients with corneal astigmatism as long as manifest refraction corresponds with topographic and biometric measurement. It should be matching. For mild to moderate keratoconus, blended approach comparing Barrett to universal and SRKT formulas is recommended. In severe keratoconus cases, standard case should be considered. These are the references. Thank you.
Thank you, Mamta, for a wonderful presentation. Naina, would you start with the
Thank you,
discussion?
Dr. Parul, and thank you, Mamta, for this interesting review article which you presented. We have two stalwarts with us, and I hope the discussion is very interesting. I will start by asking first to Dr. Himanshu, what is the preferred method of keratometry in your clinical practice? Second subpart is, what is the preferred IOL formula you'll use to reduce the hypermetropic error, and any role of optimization of A constant to prevent refractive surprises? Please share your first-hand experience with us.
So first and foremost, we know that let's build a little background to this subject. One is the repeatability of refraction in keratoconus is very poor. If you look at the one of the largest prospective trial, CLEC trial, which was done in US, multicentric trial, and they found the repeatability of refraction was, standard deviation was almost 5.5 diopter. That means multiple time you do refraction, there can be huge variability. And we all know in keratoconus on the same day, if you do refraction in 3 places, you will have 3 different refractive errors. Now, why there is variation? Is it related to axial length? Of course not. So what is it related to? Well, it's related to the curvature of the cornea, and which reflects to keratometry, right? So one most important part, the repeatability of the measurements are going to be an issue here. Now, second part, when we use any formula, most relevant formulas, whatever we have, will have almost adapter effect of keratometry on the visual outcome which we get. So if you are off by keratometry by adapter, you may be off in your refraction by adapter post-operatively, right? Now, if you join both of them together, well, in keratoconus, because the keratometry measurement what we have, or rather in any formula what we take, the formula takes one K value. So it averages everything out. It averages K1, both the hemimeridians of K1, calls one area K1, one axis K1. It averages a perpendicular axis, calls K2, averages both of them and gives you a mean K and uses that mean K. Now you think about it, by definition alone, keratoconus has to have superior inferior asymmetry of almost 1.6 diopter. Higher the keratoconus, more the superior inferior asymmetry. So such kind of cases, inherently, there are chances that the K value, what you get, total mean K value, would be away from most of the K values which are there in real point on cornea. And you go towards the center of the cornea, of course, there would be averaging, and then hence you end up getting a K value which is not accurate. And that's how keratoconus is. But the thing is, I would rather say that all the studies, whatever they did, a major thing which they actually forgot, I would rather say not forgot, but sort of oversight was, I would rather classify keratoconus central cone versus peripheral cone and then analyze the entire literature. Now, analyzing a K values or the refractive outcome of a procedure in central cone versus decentered cone is totally comparing apple with oranges, and it certainly cannot be done. And then you end up getting values which are, of course, too much off. So if we have a central cone, and if we have the X's which are, and of course, before cataract, or if you're doing refractive lens exchange, then during that period, if your X's are very similar to the subjective acceptance X's, well, we are in good zone, and we possibly can nail the outcome much better in such kind of cases. In such kind of cases, I don't even mind looking at a toric IOL. But when you have cases where there is a significant asymmetry between subjective acceptance X's as well as the objective X's, there are very high likelihood that you might end up getting a refractive surprise. Now, when you have advanced cone, the superior inferior asymmetry is such that the mean K value would still end up getting much higher than what you want, and then you end up getting hyperopic surprise. No guessing to that. So if I look at these kind of things, if I have a decentered cone, I would rather find out a way that am I able to visually rehabilitate this patient using contact lenses? If yes, and patient is going to be ready to continue with the contact lens, I won't worry about it, and I would possibly target a little more towards myopic side. If I have a centered cone or decentered cone, but patient is not willing for the contact lens, I would find out if I can regularize this thing by doing intacs or maybe topo-guided PRK with or without cross-linking, depending upon the age of the patient, and then follow it up with a cataract surgery with more regular K values. If it's center cone, well, I would possibly have a low threshold to go ahead with the cataract surgery. So yeah, long answer, but I really don't think there is any absolute truth in this thing.
So can I add a point here?
Dr. Vavik.
Yeah, Imanshu, you brilliantly cited the point to differentiate between a centered cone and a decentered cone. But would you think about measuring the posterior K value also? Because whatever the refractive index which we are taking is 1.3775. We are not taking in the posterior K value, which has already changed and would be asymmetrical. So with the IOL Master today or with Shimplung cameras, if we could measure both of them, does it matter in any way?
So, Vaishal, interestingly, there are none instruments which are reliable to measure the true posterior corneal curvature. And unfortunately, all of them are based on theoretical formulas, which are mainly derived for thinner cornea, thinner lens, and in corneas which are regularized corneas. We really can't accept that same concept in more irregular surfaces like keratoconus. The thing is the posterior corneal curvature would put your calculation off by some amount, but the main culprit is right there in front of us, which is the anterior curvature, which itself is so variable that it's difficult to get one K values and call, you know what, your cornea has this K. And how can a keratoconus have one K value, which is true K value?
But what about total corneal power that you get it on OCT? So some of the OCTs, I think, do give total corneal power. Where they actually look at the anterior posterior curvature as well as the thickness. So you probably try to overcome that refractive index issue.
So again, it's same thing. It's like, again, when we talk about total corneal power and these things, it works well in regularized cornea. But in cornea, which is asymmetric,
Yeah.
well, we are
Yeah.
surrogating entire irregularity with one K value and expecting that to work and expecting a visual outcome of cataract surgery to be wonderful.
Yeah, I think
By
it's better
chance
to
alone, we'll hit the
regularize
target in some cases.
before doing anything. Yeah.
Yeah.
Dr. Vavikar, sir, so your comment, and do you think any specific classification would help us in really, judging the type of IOL or, that we can put in these cases?
Yes, thank you, Dr. Parul, and good evening, everybody. Excellent presentation by Mamta and very good elaborate answer by Dr. Himanshu. Let us start with, we'll go through the studies. The most important point, as highlighted by Dr. Himanshu, is that we need to know whether it is a central cone or eccentric cone, right? That is one thing established. Second thing we need to establish whether is a contact lens happy patient or not. Depending upon that, our management is definitely going to change. Now we come to the third point, is that which formula to use. Okay, so there are two ways. Number one, this is of course all theoretical discussion. As Dr. Himanshu has already said, we do not know exactly what you are using. Now, sometimes luckily what happens that it is a multifocal cornea, and whatever patient, whatever lens you put and whatever the refractive patient has, some of patient seems to be very happy. But here we are talking about increasing our accuracy. Now, to increase the accuracy, let's assume that we are having a proper theoretical discussion only. First thing I would do is that decrease the grade of the keratoconus. Okay. So for that, our old classifications we need to get rid of, and we need to talk about newer classification like Retix classification. Retix classification gives weightage to not only topography, but base corrected visual acuity, RMS value, Q value, RMS means higher order aberrations, Q value, and also astigmatism.
Sir, I think Mamta has one slide on that. You have given it to her.
It has a slide on
Can we have that share, Mamta?
Yes, sure.
That slide, yeah.
Sure.
The next one, I think, yeah.
Yeah. So see, if you see that this classification is really good. Now it is very difficult to divide the keratoconus into these 4 or 5 grades. Actually, it is a continuous spectrum. Okay. But even then you get an idea what you are dealing with. Now, when you go to keratoconus beyond grade 3, everything is so vulnerable, like, so unpredictable that in such cases, if the patient wants, the best thing is to do some regularization procedure like topo-guided PRK or intacs, depending upon the K value, and get the cornea, get the cone central or regular, and if possible both, and then think what to do. Now, once you have, let's assume that we have done that, then I will see that if the central 3 mm has got a regular cone, a good cone, then I would like to see how much is the astigmatism, and I would treat that. Eccentric cone astigmatism treatment is very, very unpredictable, and best is not to do, not to attempt it. But you have a central cone and good amount of astigmatism. We always talk to the patient that we are going to debulk the astigmatism, not we are going to get 0. And then we come to IOL power calculation. IOL power calculation, we can go 2 ways. Number one is the older way, where we use the old refractive index of cornea in a Gulstrand model. In that, the best way to go is to go by EKR. Okay, pentagram EKR is certainly the best. And the newer methods in which you do not use the corneal refractive index of 1.3775, but you actually measure the anterior surface and the posterior surface of the cornea, and by using SSOCT or similar ray tracing device, and use it. Now, even with SSOCT, in normal corneas, on IOL Master 700, if you use Barrett TK versus Barrett TK 2K, by using Barrett total keratometry, the results improve by 12%. This we are talking about normal cornea. So here comes Dr. Himanshu's point that in normal cornea also, if the results are improving just by 12%, what are the chances that it will improve in an irregular cornea? And that is why the point which was raised by Dr. Vaishal Kenia is that, don't you think we should consider posterior cornea? Yes, of course, we have to consider, and SSOCT would be the best bet for that. But at the same time, we have to understand that we do not know how accurate it is. So in nutshell, this is how I will go. First is classify the type of keratoconus according to newer classification. Do some smoothing procedure or get the cone central, and then first talk about astigmatism and then approach. Now, I always calculate by both the methods, whatever number of methods are available, and try to put a mean IOL power. Of course, I have not done too many cases, just theoretical discussion.
Thank you, sir. So I have one, Mamta, can you stop sharing the slide? So I have one question is that when we are looking at these cases where you have a spectacle correction, which is good, okay, in these patients, especially these are the people who have central cone or they have mild keratoconus. And in these patients, if you have to decide about a toric and a non-toric, what would be, how would you decide that this patient is good for toric and this patient is not good for toric? Patients who have a better, best spectacle corrected vision. So
if the central 3 millimeter has got regular astigmatism, I would consider that as a very good case for toric IOL. If not, then spherical IOL with a leaving behind myopic residual and a contact lens.
What about you, Himanshu?
Same thing. So as I said, that I would look at centrality of the cone. If the cone is centered, and if my subjective and objective axes are similar, in that case, I would be really pumped up to think of a toric IOL. But if there is, and believe me, most of the time when your objective method shows some axis, your optometrist gives you totally another axis. You keep on insisting, no, this is not this, and try this thing. And he or she will tell you, no, patient is not accepting it. So that's the standard story of keratoconus. So in such kind of cases, doing a toric IOL may not be the best way. But if you have something where they both are correlating well, and as Dr. Vavikar said, cases which are mild keratoconus and better corneal surface, I don't mind thinking of toric light.
So the 2 points, Himanshu, that I have. One is that subjective refraction may not be possible in many of the cases if you have an advanced case.
True.
And second is that sometimes you have an astigmatism which is regularly irregular rather than irregularly irregular. So if you have an advanced case where you have a central cone and you have a high astigmatism, so do you think you would still attempt to do a toric IOL to debulk the cylindrical value so that you can achieve a better, best spectacle corrected vision? And if you, at all, if you decide to do, how would you plan that case?
So 2 things here, Parul, which we have to pay attention to. One is that what is your end point, or what I call final destination, which you're looking at. Now, if you think that you're looking at a spectacle independence in that particular patient, do you think you are able to achieve that looking at that particular topographic picture? If you think that that's possible or that's doable, surely we can think of whatever we want to do. Second thing, we have to look at how this patient is going to get visually rehabilitated and what is the maximum achievable visual acuity for that. Now, that has to be maximum practically achievable. Now, you may give a farmer a scleral contact lens and say, you know what, he is able to see very nicely, but if he's not going to wear that contact lens, then you might have to see that how can I possibly reduce the lower order aberration and at least give something which gives that person little better vision. But when you have, as Dr. Vavikar was saying, in advanced cases with very high RMS value, especially comma, moment you take care of the lower order aberration, you are exposing coma. So that person, if that person is somebody who is very keen on good visual outcome, as soon as you take care of the lower order aberration, you are going to give them ghosting of images. Now, I don't know whether we helped that person or not. Now, if that person was ready to wear contact lens, like Dr. Bhavika said, I would rather reduce the bulk of spherical power and those things and fall back on the contact lens. But if you think that contact lens is not possible, this is the only eye, whatever you are dealing with is a patient who is not going to wear anything. And if you are still able to reduce the major chunk of astigmatism, yeah, surely you can think of that.
So I understand that you're saying that if you have an eccentric cone or if you have an advanced cone, it's best to regularize your cornea. So
Of course.
in your practice, how often are you doing the intracorneal ring segments or a PRK preoperatively, especially in advanced cones? So I would say anything where either it's an eccentric with any reading which is more than 54, 55, where you know the patient is not going to improve beyond 624 or, with the spectacles. So in these cases, yeah.
So first and foremost, a disclaimer. I think if anybody claims that they have done loads of cases, either they're lying or they may have different definition of what we are talking about. So I really don't think any one of us would have loads of experience in advanced keratoconus, doing only cataract surgery, and that too then again doing toric IOL. So such kind of cases become less and less in the practice. Having said that, I have done a few cases. They do well, but that's a very blanket statement to say they do well compared to what? I mean, anything in science we say somebody is doing well, there has to be compared to what? And this would be totally uncompared outcome which you would be talking about. Having said that, most of the time cases where I find that the younger generation people with, what happens in many of these keratoconus cases, keratoconus associated with VKC, having steroid since young age, PSC develops much earlier. And these are young age patients where they can actually potentially end up in the cataract surgery. In such kind of cases, can be a very good candidate for surface regularization procedure. Nowadays, I fall back upon topo-guided PRK more than the Intex, purely because the outcomes are a little more predictable with topo-guided PRK compared to Intex. Intex is nice, but the predictability of outcome is not as great with Intex. But if I have to use Intex only in one case, well, that would be post-LASIK ectasia. So if I have post-LASIK ectasia with keratoconus, with cataract, I would certainly do Intex first and then plan my cataract surgery. Other cases, well, my preference would be more for topo-guided PRK.
Dr. Bhavika, your opinion?
Yeah, I'll give my opinion, but I would like to ask question to Dr. Himanshu. So between topo-guided PRK and Intex, what is your watershed line? That means beyond this, you would like to think of Intex as a first option and below this topo-guided PRK. Because Intex can flatten the cornea by 5 or even 7 diopters, whereas topo-guided PRK flattens the cornea by 2, 3, maximum 4 diopters.
So basically, my idea of Intex would depend upon what kind of flattening I'm going to achieve. Now, why I said post-LASIK ectasia as my preferred thing. If you think about post-LASIK ectasia, most of them, they have ectasia which is quite decentered, inferiorly decentered. Most of them, they have pretty okay or pretty regularly flat cornea in superior part, which is not affected part, and most of them their spherical equivalent is not that high. So in such kind of cases, that inferior elevation which is there flattening that alone would make the surface much more regular and would give much better spherical equivalent compared to anything else which you use. So similarly in INTRACS, if we are looking at somewhere where we have the corneal, the X's which are already flat X's, which are within your acceptable limit, and they're not having still quite steep K, where the spherical equivalent is not very high. In such kind of cases, INTRACS can be fine. But having said that, the amount of control which we have in terms of outcome is far beyond comparison between topo-guided PRK and INTRACS. So if I get a chance, I prefer topo-guided PRK. If not possible, INTRACS certainly comes the next in my armamentarium.
When we are talking about topo-guided PRK, we are talking about corneal thickness. So we are definitely looking somewhere where we are not looking a K reading or the keratometric readings which are more than 52, 53 or 55, I think. But when we are talking about INTRACS, we are looking at the cases where it is a severe cone. So where probably an
Not exactly, Parul. I won't say that. Even in INTRACS, if you look at anything which goes beyond 60, 65 they claim, but most of the time, by then the corneal thickness would have gone down significantly. So yes, it can be done in any cases. The problem with INTRACS is that it's a segment which you're putting into the stroma of the cornea. If you do not have enough cornea behind the ring as well as in front of the ring, either the ring can lead to melting of the posterior stroma and can intrude inside, or it can melt the anterior stroma and it can extrude out. So the magic number is almost 120 to 150 micron. No, 120 is still okay. 125 micron behind the ring. And the depth of the ring has to be somewhere around 300 micron plus. So if you look at in that zone, you are looking at corneal thickness of 450 micron and all those things. So it's not that very advanced cone we can do INTRACS, because that self can have its own issues.
So what about doing a DALC?
Of course, that's so the idea is that when we look at the cone, we decide that is it very advanced cone, an irregular surface? There's no point looking at all such kind of thing. In that case, a DALC or PKP, whatever works best, would be the better choice. And then follow it up with, and if the cataract can wait, I would rather do a corneal transplant procedure first. Wait for the surface to become regular, or at least give me an idea that if I can get it more regular, and even if required, I can use toric IOL or can have more predictable outcome. If I think that the keratoconus is not very advanced, cornea is not that bad, then comes the other discussion what we had: central cone, peripheral cone, how advanced the cone is it progressing, do cross-linking. If it's not progressing, then based on what discussion we had, we can go ahead, central cone, maybe toric, decentered cone, make it more regular.
Okay. Arun, let's welcome Dr. Lahane sir, please. Lahane sir has just come in.
Yeah.
Yeah.
No, you continue.
Okay, continue. Okay, sir.
I'm just listening. Go ahead.
Okay. Vavikar sir, I just want to ask one thing, is that when we are looking at a mild cases where we think that we will be able to put a toric IOL, so is there any scope of using premium IOLs like EDOF toric or a multifocal toric? So do you think those cases where it's a very, very limited numbers, I know it's a very mild cases, so do you think that is a possibility and we can try to achieve metropia both for distance and near?
Usually one of the most important points while considering suitability for any kind of a trifocal, quadrifocal or EDOF lens is that the higher order aberrations have to be really less. And having a keratoconus with very less HOA is very difficult to It's
a very central cone. I think it's a arrested form of keratoconus if you see sometime.
maybe.
Probably that is the case where we may have. Vaishal, do you have any?
The answer to that is how sure you are that you're going to hit emmetropia, beating your chest there and promising patient that, what, I'm offering you toric multifocal, you're spending a huge amount of money, but I'm not sure about the outcome.
That is
You're
where
not sure.
probably our post-surgery PRK or post-surgery piggyback IOL will probably help us if we are over-promising these patients with emmetropia for distance and near.
So other interesting part is that in surface which are asymmetric surface, even if we do topo-guided PRK, we may be able to reduce the astigmatism partly or something, but it compensates by increasing the sphere.
Yeah.
So suddenly, whatever you have decided and you've done, you may have hit your emmetropia with your lens. Now you will have some kind of myopia, which is sitting there, or rather hyperopia, which is you'll be steepening. So I think it's better to avoid such kind of thing and allow them to wear their other glasses.
So Vaishal, you also, I think, have some clinical experience of these cases. So
Yeah.
can you share?
So basically, the point today told was the most important thing is the EKR. You should do a pentacam and see the spread of the K value before planning whether it's a toric you want to put or whether you want to put a non-toric. See, in central cones, you may also put a non-toric if the astigmatism is not much. See, I have done cases where there are subclinical keratoconus, only there is a posterior elevation. And this was just on cataract screening, we came to know that the patient has a subclinical keratoconus. So in such cases, the spread of the EKR helps us how the central 3 millimeters, how the spread is. So in these cases, I have been using the Barrett TK formula. And lately, after Dr. Barrett published his new data on keratoconus, I've been started using the Barrett true K measured value. So definitely the TK value, when you account for it, the measurement, it has improved. But mind you, these are only in mild cases, less than 48 diopters, where Dr. Himanshu rightly said that if we are not able to measure it properly, then whatever formula you use, you're not going to hit. But where it's a very mild case or a subclinical keratoconus, where the derangement is not much, definitely the role of posterior K measurement is there. And that's why measuring the TK value and using the true K, what has happened is it accounts for the regression. It uses a regression formula. So using the measured posterior K as well as the regression, it helps to achieve more emmetropia. And why SRKT worked much better than the fourth generation formulas was that the SRKT usually showed slight amount of more myopia, which counterbalanced the hypermetropia, which was caused by measurement of the when you're measuring the intraocular calculation in a keratoconus eyes. And that's why SRKT was found to be more superior than the other formulas. But in today's time, there were a lot of formulas like Holiday KC formula, Kane KC formula. But today, Barrett True K measured has worked beautifully well. And I have a series of around 30 cases, but these are mild cases. Mild case where grade 1 less than 48 diopters, where it has done extremely well.
My question to the panelists is, with myopic axial lens, any special concerns in measuring them in keratoconus eyes?
So if you have myopia associated with keratoconus, so do we have anything which we should be worried about? Sir, or Himanshu, anyone?
Ravikar, sir. You can go.
See, basically, when we are talking about keratoconus, it is not the axial myopia. It is possible that patient has axial myopia also, but it is not axial myopia. It is the steepening of the K and overestimation of the corneal power, and something which goes wrong in the ELP determination. So from that point of view, I don't think I will make any changes. I will go exactly the way Dr. Himanshu and Dr. Vaishal have described.
Himanshu, any comments or?
I think Dr. Vavekar hit the nail in proper place, that we are talking about curvatural myopia, but if at all we have axial myopia, treat that spherical equivalent calculation based on what your from what formula works best in your hand for the axial myopia, and that's as simple as that.
Vaishal, just to your comments that you gave previously. So I just wanted to know if you can tell for the general public how an EKR spread would look, in which case you would attempt a toric or a premium IOL, how a map would look, So people don't know about it. So can you just talk about that?
See, basically, putting a premium lens in a keratoconus is a big question mark. As Dr. Vavekar sir said, that if the higher order aberrations are much higher, then putting a premium lens is a disaster. And as Dr. Himanshu said, it's a multifocal cornea. So already the cornea is multifocal, and you're going to put a multifocal lens, you're going to create a problem. So in the message is that in these cases, a monofocal lens would be much better to put. And EKR spread, why it is important? Because EKR gives you the anterior as well as the posterior. It gives you an equivalent K reading. So you know the spread. If the central 3 millimeters, so it gives you a spread from from the center to the 8 millimeters, how the spread of the K value is. And what you are interested is the central 3 millimeters, how the spread is. So if the spread is more regular in that case, then you can go in for a toric lens. So this is for deciding whether you want to go for a toric lens or a non-toric lens.
So Vaishal, I understand that if you get a very tall peak in the central 3 millimeter, it is a good case to go ahead with a premium IOL. And if you get a flat base or a very widely spread out lower
value, that's an irregular cornea.
Yeah, you would not look at
perfectly fine,
right? Second thing is that when you're looking at a severe keratoconus, most of the formulas do not allow you, online calculations do not allow you to feed any values above 55. So when you look at Barrett's, it does not allow you less than 30, more than 55. So in these cases, I think we have to resort to the original old formulas like an SRKT or a SRK2.
Parul, what I want to tell you is that, as Dr. Himanshu has told, that in severe cones, the measurement of the cornea curvature, you need to understand, is asymmetrical. It's not the same K all across all the meridians. Even each hemi-meridian is different. So predicting with any formula you put, it's going to be a guesswork. So in those cases, you can go in with formulas which are able to take in that K values and then go ahead. I know the Barrett takes around up to 55 K values, but other than that, you can use a normal K values and then tell the patient that you can put a piggyback lens if that may be the case. But you cannot guarantee the patient some near emetropia. And as one of these cases series showed that in severe cones, the hypermetropia was more than 2.5 diopters. So you are really off.
Yeah. Okay. So we'll just go to Dr. Sengupta. Dr. Sengupta, yeah. Are you here? I just would like your comments on the article and.
Yeah, I'm here.
Yeah.
So I just wanted to quickly share my screen, if that's okay with you.
Yes. Yes.
Yes.
Just a second.
I think we are going to overshoot a little bit this time. Sir, is it okay?
Yeah. Please.
Maybe about 5-10 minutes more. Yeah.
It's okay. It's okay. Very interesting.
Because I think you're able to see my screen.
Yes.
Yeah.
A couple of things. This is a review article and not an original article. There's not much statistics to be discussed, but overall, what we can discuss is, when you're looking at a study, which is like a review, systematic review. The thing that you should use to see whether it is done well is called the PRISMA checklist. So it's a 27-point checklist, and it, so this study adheres to some of that and not to a lot of that. So I would say that it's not really up there in terms of how in terms of the quality that is there. Second thing, so we're talking only about this study. The second thing that they did is, this is the inclusion criteria. So if you see, they say there is no history. So cataract surgery nice with keratoconus for patients with no history of ocular surgery in the past. So all these studies have patients who have not had any cross-linking, who have not had any intacts. Of course, transplant is all right, but when you have patients with advanced disease, like so many of these have groups with more than 52 or 55, it's relatively sort of surprising to see that they have included only those studies which have had no previous sort of treatment. So so this is a better sort of review on cataract surgery nice with keratoconus. So here what they say is preoperatively. So this is basically what all of you have been discussing. Preoperatively corneal cross-linking and intrastromal corneal ring segments can be considered in order to provide stable keratometry values of intraocular lens for IOL calculations. So basically stabilize the cone and then go ahead and do cataract surgery to have or to give predictable surgical outcomes. But so this study, this review article actually has excluded all these kind of studies. So then you're not left with too much. And I don't think a lot of the recommendations from this article are really relevant to what we're doing today. And then what they have said is that there has to be explicit mention of how IOL power calculation was performed. That includes, of course, keratometry and axial length. But then there are some studies where that has not been provided, but still they have been included. For example, let me just quickly show you. So this is a paper by Alio et al., which has 17 patients, but the article does not specify how keratometric values were measured. However, it has still been included in the study overall, right? So it's a little bit confusing as to what, which studies have been included and which studies have been excluded. In the results, they clearly don't mention the cone location, which I think all of us have already mentioned. When you look at the table, I think this is not really helpful at all. They say there are these many eyes, but they don't mention mean age of patients in the study. So are these patients relatively young, undergoing refractive lens exchange for visual rehabilitation, or have had cataract and need actual cataract surgery? Something that I think both scenarios are quite different in terms of patient expectations. And so this definitely needed to have a column on age. And I think most importantly, what is the 95% confidence interval of, or let's say the range of refractive error, which was seen in each of these studies, right? So this Kamiya et al. Had 102 patients, and that final refraction varied from, say +4 to -3 or whatever that may be, So that is something that had to be provided, but overall it has not been provided except for one study. And there is only one study in this whole thing who have actually used the Barrett universal formula. And I think Dr. Vaishal has sort of touched upon this a little bit, but it's surprising to see that Barrett's formula being overall considered to be probably closest to accuracy, at least in normal eyes. And most of these other studies have not used Barrett's universal, or many modifications or iterations of the Barrett's which has now come up. And they are all relatively recent studies, 2018-19. So then it's, I think, sort of unfair to say that SRKT is the most accurate formula, because a lot of newer formulas and iterations have not been actually compared against. So I think these are some of the takeaways from me on this paper.
Yeah. I think I just want to one comment that Savini et al., the article we should talk about. So if you see the table that they have given, so in the milder cases, the grade 1 cases, they have shown that most of them have an equivalent results, except that I think SRKT had a slightly little better performance. But otherwise, most of the formulae, the IOL calculation was fairly good in the mild cases. In severe cases, I think it was bonkers for all. So, and Nena, I think we'll be ending. So we'll just have a quick take-home message from each panelist. So Dr. Vavikar and Dr. Himanshu.
Yeah, whenever we have a case of keratoconus, for cataract. I think most important is that we have to spend something like 15-30 minutes with the topography of the patient, see all the maps, okay, and then take a call. That would be a message.
Himanshu?
I would say, as you rightly said, early cases, mild cases, you're okay, and you can still be fine to go ahead with your cataract surgery. Having said that, these are special scenarios, and we must explain to them guarded visual outcome and potential refractive surprises. In case of advanced cone, or rather I would say decentered cone, I would rather try to have regularity of the surface and then plan the cataract surgery if it's possible. If it's very advanced cone, and if I have to do a corneal procedure like topoguided PRK or Intex, I would rather do that. A cone which is such that where nothing can be done, I would rather do a corneal transplant first, wait for the graphose junction to heal, surface stabilization, and then go for the cataract surgery.
Your preferred method of keratometry in these cases? Biometer versus pentacam versus...
No, so I would never ever rely upon one particular thing. I always consider pentacam as my topographic measurement partner, and IL Master 700 as my keratometric preferred partner. And when both of them match each other, I would be really happy. When they don't talk to each other, well, I'm not happy there.
Vavika,
Well
sir.
said, well said.
Yeah, basically, same thing what Dr. Himanshu said, that I would take a reading on 3 keratometers and then decide which one to choose. The golden rule that the central 3 millimeter, innermost ring we have to take, does not hold here true, because the cone, if it is eccentric, the apex is shifted, and therefore we are not going to, you are not getting the effective optical zone. And that is what we need to see on topography, whether it is the central cornea you want to consider, or it is the effective optical zone around the visual axis you want to consider. And depending upon that, I will decide K readings.
I think with this, we have already overshooted our time. So we
I'll
will...
ask the president, sir, just to do the concluding honors for the meeting, and followed by entered presentation and Thanksgiving by Dr. Rajesh Joshi.
Yeah. Big thank you. Wonderful discussion went on for this review article, and well moderated by Dr. Parul and Dr. Naina. And the panelists, as usual, were fantastic, Dr. Himanshu Matalia and Dr. Vavika sir. We are honored to have Dr. T.P. Lahane sir also. So we'll have a word from him too before we have the video, the promotional video from the entered people. And Mamta, very nice presentation. The way you have done it, fantastic. And of course, the entered people, they are always there as the technical support to help us. So, Lahane sir, a word from you, sir.
Hi, good evening, everybody. I think I was hearing this, and Himanshu and Vaisal and Chandrasekhar, they were really very knowledgeable and very good answers they were giving. And Parul and Naina, they have prepared good questions. And I really appreciate this CME, Vaisal, very good CME.
Thank you.
Only thing I want to ask Himanshu, or I will just put in his mind, who is the person who will prevent not to do the toric IOL when it is not indicated in the keratoconus? There are so many guidelines. See, I will tell you. In keratoconus, they put a toric IOL.
Yes.
Patient will come to me and ask, this, please remove this lens because I can't walk. Okay. So now, few patients, they go in the court of law. And in the court of law, there are no rules when not to put the toric IOL in keratoconus.
Yes.
So there should be some guidelines. So why I want to tell you, offensive practice should be prevented. And the teacher like you, I think we must prevent such type of offensive practice, and it is very difficult to answer. Now, see, my cases in Mumbai were decreasing. Now, in last 8 days, I have got 4 cases. Out of that, 3 are keratoconus. One is a retinal detachment. So it is very difficult because they have put toric oil. And another thing I will tell you, piggyback oil on the toric. You tell me what is the answer? Because see, I asked Sumit, कि बाबा ये तुम्हारे लोगों ने किया है, tell me इसका answer. बोले Papa, there is no answer. So it is very difficult. So we'll have to do something. And I think Himanshu, whenever you are teaching, what we teach, what not to do. So this is very, very important. You will have to teach these people what not to do and what is to be possible and contraindications for the toric in keratoconus.
Very true. Well said, sir. So I totally agree with you. One thing is, I would like to answer this thing by asking myself when I'm offering, am I bringing anything better to this patient rather than bringing to me something extra? Now, if it is me which is getting something extra and not the patient, I don't think it's worth doing anything. But if I'm able to help that patient by giving something extra, I certainly would look into that. To be very objective, a central cone with objective and subjective axis correlating with each other. And if you think that, as Vaishal was saying, that if the astigmatism is low, might as well just go for monofocal and give them the glasses. But if it's high astigmatism, and if you're reducing the bulk, surely go ahead and tell patient that this is why I'm doing. Now, many times our problem is poor communication to the patient. We do not tell them why we are doing what we are doing. So if we are able, our conscience is clear and we tell them why we are doing what we are doing, I think they would understand. But that's an excellent point, sir. I think we all should think about such thing.
Thank you.
Very well put up. Very well put up, Himanshu. What I would suggest is, why don't we have preferred practice guidelines for such procedures? What Dr. Lane sir has said is very important in the court of law. It doesn't stand testimony to cases where the new procedures are done unless we have standard guidelines, a gold standard to go back on. What do you say on that?
No, sir, it can be done, sir, but it's a very specific niche area. Having a guideline about one particular niche area can become a little difficult, but when AIOS is doing something, making big guidelines about such kind of thing, like Dr. Lane was saying, that if AIOS is making a guideline about, say, toric IOLs or something, there such kind of things should be included, that, okay, in keratoconus and toric IOL, where should you not do and where can you do it? So as you rightly suggest, it can be certainly part of guidelines.
Himanshu, what I'm doing, I'm going for the articles in the index journals, and I'm supporting the doctor by saying that in the index journal, these are the studies, and according to study, he has done, and so he has not done any wrong. So, but every time, this is not going to help us in the court. So I think what you said is true. Yeah, we can ask AIOS to formulate the guideline. But what you said is correct. If you are adding to the patient, do it. If not, don't do it. I agree on that.
Very noble thought by Himanshu. Very nice. Vaishal is doing a great job. He is running the show so nicely, sir. I had handed over this committee as a chairman. And of course, co-chair is Dr. Sen Gupta. Both are doing fantastic jobs. And of course, our moderators, Parul and Dr. Naina. Of course, Parul is there always.
Parul is a key person, sir.
Two moderators each time to give a chance. So Parul is coming up with fantastic ideas and review articles. So nice about you. Very good, Parul. You are doing a great job.
Thank you.
I'm extremely thankful. This committee is doing great work out of all the committees. Of course, rest of them are
it's Parul's hard work, sir. Parul is totally dedicated, sir, and doing a lot of back work. So it's not seen, which should be highlighted here, sir.
A round of applause for her.
Absolutely.
Thank you, Vishal.
Great going. So now let's have the promotional video from the enrolled people before we say the Thanksgiving by Rajesh. Over to you. Dhairya, please show your video quickly. Yeah, Rajesh now.
That was really a wonderful discussion on the IOL power calculation in keratoconus. Still, there is no agreement with which formula and IOL power to be implanted. So a lot of research need to be done in this aspect. I thank Dr. Lahane sir, Dr. Wabikar sir, Dr. Himanshu Matalia for sparing their valuable time and giving their inputs. Thank you, Dr. Mamta, for your wonderful presentation. Many thanks to Dr. Parul, Dr. Naina, Dr. Vaishal, and entire team of eJournal Club for taking all the efforts. Special thanks to Dr. Sabyasachi for highlighting on statistics. And thank you all the delegates who are joined to have the feel of this journal club. My thanks to Entor for technical support. Thank you all and good night.
Yeah, before we sign off, let's have the gallery view, all video on, all the panelists, and we have a quick pick before we sign off. The area to take a gallery shoot, please. Quick. Is he there? Yes or no from you?
The area.
Yeah, taken, sir.
Thank you.
Thank you very much. Good night, sir, everybody.
Thank you, Himanshu. Thank you, sir.
Thank you. Thank you.
Thank you.
Thank you,
Himanshu,
Himanshu.
Thank you. Himanshu,
I really enjoyed.
Thank you, everyone.
Wabikar sir, thank you.
Chandrasekhar, thank you.
Lahane sir, Wabikar sir, Matalia, Dr. Matalia, everybody, Parul, and Naina, and Vaishal, of course.
Jignesh, big thank you to you.
Yes, sir. उद्या आहे मीटिंग परत CME आहे. Vora, how many are the attendees?